Welcome to today's deep dive. I am so glad you are joining us for this one because we're tackling something that I think touches a lot of families.
Yeah, it really does.
Our mission today is to explore the intersection of pediatric mental health conditions and, well, these really innovative school-based delivery systems.
Right, because the way we deliver care right now is, it's fundamentally flawed for a lot of kids.
Exactly. So, for our sources today, we are looking at two really compelling documents. First, we have a very compassionate clinical briefing on pediatric Tourette's and co-occurring OCD.
Mm-hmm.
And second, we have an operational overview of this program called MentalSpace School. It's a comprehensive K-12 mental health support program down in Georgia.
And looking at both of these together gives us such a complete picture.
It does. Okay, let's unpack this. We have this core tension, right? We have brilliant, highly effective evidence-based therapies for kids.
Yeah, the clinical science is actually amazing right now.
But they are basically useless if families can't actually access them. So today, we are looking at how this one program in Georgia is bridging that massive gap and honestly changing the whole narrative around kids who just get labeled as difficult.
Right, because before we can even talk about the systemic care model, we have to understand the kids themselves.
Yeah.
We need to understand the very real and honestly deeply misunderstood neurological challenges these kids are facing every single day.
Right, the invisible struggle. The briefing goes into pediatric Tourette's and the co-occurring OCD that often comes with it.
Which is incredibly common, yeah.
And it outlines the signs that families usually notice first. So you have these sudden repeated movements or sounds, the tic.
The physical or vocal tic.
And then on the OCD side, you see these rituals, checking things over and over or repeating certain actions because they're being driven by these completely overwhelming, anxious thoughts.
And that distress just multiplies when you put the child in a stressful or highly social setting.
Like a classroom.
Exactly. What's fascinating here is the crucial reframing that the text emphasizes. It explicitly states that these symptoms are neurological. They are not behavioral.
That is such a huge distinction.
It changes everything. The tics aren't the child acting out.
Right.
And those intrusive thoughts, the rituals, they aren't the child being difficult. Their brain is literally misfiring.
I was trying to think of how to describe this, and it's like trying to stop a sneeze by just wishing it away.
Oh, that's a really good way to put it.
Right. Like imagine sitting in a completely silent math class, feeling a sneeze building up in your nose, and knowing that if you actually sneeze, you'll get sent to the principal's office.
It sounds like torture.
It is. You wouldn't discipline a child for sneezing.
Yeah.
So we absolutely have to stop punishing these kids for neurological symptoms.
Absolutely.
And the briefing uses this phrase that just really stuck with me. It says, families don't have to white-knuckle through this anymore.
Yeah, that visual of just gripping the steering wheel, right? Just trying to survive the day.
Completely exhausted.
Right.
So once we stop treating these realities as discipline problems, how do we actually help them?
Right, moving from just having empathy to taking real clinical action.
Exactly, because the sources mention some very specific evidence-based treatments.
They do. They highlight CBIT for the tics and ERP for the OCD.
Okay, let's break those down. What is CBIT?
So CBIT stands for Comprehensive Behavioral Intervention for Tics.
Okay.
And it's a highly targeted therapy. The clinician basically trains the child to recognize the urge that happens right before the tic.
Like the tickle before the squeeze.
Exactly. And once the child can feel that urge coming on, they are taught a competing response.
Wait, what does that mean?
It means they do a specific physical movement that makes the tic impossible to do. So if the tic is jerking their neck, they might subtly tense their core or their neck muscles so the head physically cannot jerk.
Oh, wow.
Yeah. And over time, doing that competing response actually helps take back control. The urge itself starts to decrease.
That is incredible. And then what about the OCD side, the ERP?
Right. So ERP is exposure and response prevention.
Okay.
This is where the therapist carefully exposes the child to the thing that triggers their OCD anxiety, but then supports them in not doing the ritual they normally do to cope.
So they just have to sit with the anxiety.
Yes. They learn that the anxiety will eventually peak and then come down on its own without them having to tap the desk 4 times or wash their hands again.
Why?
It literally helps them take back control so the child and their whole family really can finally just breathe again.
Okay, so these therapies sound incredibly effective, but I have to push back here.
Sure.
These are highly, highly specialized interventions.
Already specialized, yeah.
So how does a working, stressed-out family actually get a child to a specialty clinic for this kind of care without completely upending their whole lives?
That is the big question.
Like, you have to take time off work, pull the kid out of school in the middle of the day, drive an hour across town. I mean, it's just not realistic for most people.
No, it's not. And that's exactly why the delivery system has historically been the biggest barrier to care.
Right.
The therapies exist, but getting them to the kids is a nightmare. Which brings us to the second source document.
The MentalSpace school model in Georgia.
Exactly. They are answering that exact logistical nightmare.
Okay, here's where it gets really interesting. Because they aren't just opening another clinic. They are bringing the clinic into the K-12 classroom.
Yes. They embed dedicated therapist teams for each specific school.
And it's not just, a counselor who visits once a month.
No, the document specifies these are dedicated teams offering same-day teletherapy.
Same day. That's unheard of.
It is. And these therapists are licensed, diverse, and culturally competent, which the operational overview highlights as a huge priority.
So if a child is having a crisis, like an OCD spiral in the middle of second period,
They don't have to wait 3 weeks for an appointment. They get same-day teletherapy right there in a safe, private space at the school. If we connect this to the bigger picture, this is a massive shift.
how so?
We are moving from a reactive, external healthcare model where you wait for the kid to fall apart and then ship them off to a clinic to a proactive, embedded model.
You're treating them in the environment where the stress is actually happening.
Exactly.
But, okay, anytime you mix healthcare and public schools, you run into a mountain of red tape.
Oh, absolutely. The bureaucracy is intense.
Right, because you have privacy laws for hospitals and privacy laws for schools.
Yeah, high pay and FERPA.
And they don't usually play nice together.
But the MentalSpace model is designed specifically to be fully compliant with both HIPAA and FERPA.
Yeah.
They secure the medical data while still legally looping in the school staff who need to know how to support the kid.
That's a huge hurdle cleared.
Mm.
But then there's the cost.
Mm.
I mean, specialized therapy like CBIT or ERP,
Yeah.
that is expensive.
It is. But the document points out something amazing. For Medicaid patients, the cost is $0.
Wait, really? $0?
Zero. And they also accept a massive range of commercial insurances.
Let me look at the list here. They take BCBS, Cigna, Aetna, UHC, Humana, Peach State, CareSource, and AmeriGroup.
Yeah, they cast a very wide net.
So they are completely removing that financial barrier.
Which we really need to pause and think about. The socioeconomic impact of that $0 for Medicaid detail is profound.
Oh, for sure.
Removing the financial barrier is what truly allows families to stop white-knuckling through these crises. You aren't just rich enough to buy your kid a cure, it's democratized.
But even with the cost covered for families, schools are still bound by state budgets and laws.
Right.
And looking at the operational document, I noticed something incredibly timely.
Oh, the legislative deadline.
Yes. They mentioned providing compliance support for something called HB 268. It says the deadline is July 2026.
Right.
For you listening at home, today's date is literally July 4, 2026.
Yeah.
Meaning schools in Georgia are hitting this exact, crucial legislative deadline right now, this week.
It's happening as we speak.
So what does a mandate like HB 268 actually do?
Well, these kinds of state mandates basically tell schools you have to have a documented operational mental health crisis protocol. You can't just call the police or an ambulance anymore.
But they don't usually give the schools the money to build that protocol.
Exactly. So administrators are panicking, but MentalSpace steps in and says, we already built the infrastructure, partner with us, and you are instantly legally compliant.
Wow. So it solves the school's legal headache and gets the kids free care.
It's a win-win.
So when you combine these targeted neurological treatments, the CBIT and ERP, with this hyper-accessible, zero-cost, fully compliant delivery system, what actually happens?
You get some pretty staggering results.
Let's look at the measurable outcomes on the ground from the overview.
The numbers are really something.
They report an 89% improved attendance rate
Which is huge.
and a 92% reduction in anxiety,
92%. That is a life-changing metric for those kids.
and then an 85% family satisfaction rate. So what does this all mean when you look beyond just the individual therapy?
Well, this raises an important question. It challenges how we traditionally view education and mental health.
How so?
Because the MentalSpace overview lists a whole broader ecosystem of services they provide.
Right, I see that. It's not just the one-on-one student sessions.
No, they are doing crisis intervention, suicide and violence prevention, And really crucially, staff wellness and family counseling.
Wait, staff wellness. Why are they treating the teachers?
Because you can't just treat the student in a vacuum.
Right.
If a child is learning how to manage their OCD, but their teacher is completely burnt out and triggered, and the parents at home are stressed and don't understand the therapy.
The kid is just going to regress.
Exactly. You have to treat the whole ecosystem. By including staff wellness and family counseling, they are supporting the entire environment around the child.
That makes total sense. That's how you get an 89% jump in attendance.
You fix the environment, you fix the attendance.
That is just incredible. Okay, so just to recap our journey on this deep dive today.
Yeah, it's been a lot of ground covered.
We started by understanding the very real neurological nature of conditions like pediatric Tourette's and OCD.
Right, moving away from seeing them as behavioral problems.
And we looked at those highly specific interventions like CBIT and ERP that actually give kids their control back. And finally, we explored this revolutionary hyper-accessible delivery system from MentalSpace School in Georgia that actually gets these therapies to the kids who need them.
Right, where they already are.
Exactly. So for any families or school administrators listening who are looking to take the next step, especially with these new compliance mandates hitting right now,
You definitely want to check out the contact info provided in our sources.
yes, you can reach out and explore their K-12 programs by visiting mentalspaceschool.com.
Or you can email them directly at mentalspaceschool@peruptherapy.com.
I highly recommend looking into it. And I want to leave you with one final thought to mull over as we wrap up today. We have just seen the data, right? Embedding mental health care directly into schools, the place where kids spend the majority of their day, can yield an 89% improvement in attendance.
It's massive.
But what would happen if we applied this exact embedded care model to other childhood environments?
Oh, that's interesting.
Right. Like what if after-school sports leagues or local community centers or summer camps adopted this model?
Just put the care everywhere the kids are.
Exactly. How much human potential is just out there waiting to be unlocked simply by putting the clinical support exactly where the kids already are?
It's a really powerful question.
It really is. Well, thank you so much for exploring this with me today, and thank you all for listening to this deep dive. We will catch you on the next one.